Hey guys, Dr. Carmen Bryant here with NursingSchool911.net, and I'm back with another video about hemodynamics. So if you haven't watched the first video about hemodynamics, which talks in detail about blood flow through the heart, I would highly recommend that you watch that first to get a good grasp on that concept, and then come right back and watch this one where we're going to dive into these specific values related to hemodynamics. All right, so the first value that I have here is CVP, or central venous pressure. The normal value that I teach my students is going to be 2 to 6, and I want to just say, make sure that if you're not one of my students, that you use whatever values that your instructor gives you, okay? But if you are my student, hey, these are the values that you need to know, okay? All right, so 2 to 6, CVP. CVP is a direct measurement of pressures within the right atrium. So CVP and right atrial pressure are totally interchangeable terms, all right? We can measure CVP simply through connecting CVP tubing and hooking it up to a transducer and to the monitor with the distal port of a central line. All right, we don't have to have a pulmonary artery catheter to get CVP readings. So this is really good that we can do this, because CVP gives us some really valuable information about our patient's fluid status. So what affects CVP? Well, hypovolemia versus hypervolemia, all right? So our CVP reading will be low when volume is low. So we have patients that are hypovolemic, that are dehydrated for whatever reason. Maybe they have diabetes insipidus and their urine output is crazy high. That would significantly decrease CVP reading values. On the flip side, if we have someone, let's say, in renal failure or CHF, and they're in a state of fluid volume overload, CVP will be high. CVP gives us really good information as to whether or not our fluid volume replacement is effective for our hypovolemic patients, for our septic patients that we're giving fluids to that because they were hypotensive and hypovolemic. CVP can immediately tell us, hey, it's going up, it's increasing. So the fluids that we're giving are doing the job and getting that volume up where it needs to be. All right, so that's CVP. CVP, right atrial pressure, ranges from 2 to 6. Next, we have cardiac output, and the value here is 4 to 8 liters per minute. So cardiac output is the volume in liters being ejected from the left ventricle every minute. So what determines cardiac output? It is stroke volume and heart rate. Also, contractility, or the pumping effectiveness of the heart, affects cardiac output. So if we take stroke volume, which stroke volume is the amount in liters ejected from the left ventricle with each heartbeat, with each pump, and we multiply that times our heart rate, that gives us cardiac output. So if heart rate goes up, cardiac output goes up. If stroke volume goes up, cardiac output goes up. Just as if if heart rate drops, cardiac output will go down. If contractility of the heart is significantly affected, cardiac output will go down. For example, if a patient has a massive myocardial infarction and they're left with a bunch of dead myocardium, a lot of dead tissue that doesn't pump effectively, then that causes cardiac output to decrease, which is a big problem, that contributes to those signs and symptoms of congestive heart failure. The heart is not pumping as it should because that muscle tissue has died, and so cardiac output has decreased, and therefore tissue perfusion has decreased. just leading to all kinds of, different manifestations associated with congestive heart failure. But at the heart, at the center of what's the pathophysiology that's leading to all those manifestations associated with CHF is a decrease in cardiac output. All right. Next, I have cardiac index, and that ranges from 2.5 to 4 liters per minute. And cardiac index is a really good measurement. It just takes into account your patient's body surface area when reporting cardiac output. So a good number to remember, cardiac index, is 2.1. And the reason being is that a cardiac index of less than 2.1 coupled with a systolic blood pressure lower than 90 or hypotension equals cardiogenic shock. Okay, so a very, very low cardiac index coupled with hypotension means that your patient has progressed to something that we never want to have to deal with, and that's cardiogenic shock. So remember that number. The next number I have listed, or the next value, is SVR, and this is systemic vascular resistance. The value there is 800 to 1200. What determines systemic vascular resistance? Basically, systemic vascular resistance equals systemic vascular tone. Well, what affects tone? And that is how either constricted or dilated our vessels are, right? So think about vessels that are very vasodilated, okay? When the heart is pumping into very vasodilated vessels, would we say that the resistance is high or low? Well, it's going to be low. On the flip side, if vessels are very vasoconstricted, and the heart is trying to pump into constricted vessels, then the resistance is high. So vasoconstriction increases systemic vascular resistance, whereas vasodilation decreases systemic vascular resistance. So why do vessels vasoconstrict or vasodilate? Now let's go back to, let's say, our patient in cardiogenic shock. Okay, we know that cardiac output is significantly decreased. So that means that tissues are not being perfused like they should because cardiac output is significantly decreased. So vessels, in response to that low cardiac output, are going to vasoconstrict, which helps to increase tissue perfusion. So very, very low cardiac output leads to vasoconstricted vessels, which increases systemic vascular resistance. So in a state of low cardiac output, systemic vascular resistance will increase, okay? So think about it that way. Let's say in a state of septic shock. In a state of septic shock, we know that there is massive inflammation that takes place and leading to massive vasodilation. This is why fluid volume replacement is so very important in our septic patients before they get to that shock state, right? Fluids. But so that massive vasodilation that occurs in a patient with septic shock leads to decreased systemic vascular resistance, okay? So vasoconstriction, SVR is up. Vasodilation, SVR is down. So finally, we have our last value, and this is pulmonary capillary wedge pressure. You will also hear it referred to as pulmonary artery occlusion pressure, or just simply wedge pressure. But the normal value there is 8 to 12. So I am a visual person. I'm not an artist, but I like to see what I'm trying to take in when I'm learning. So I have a very poorly drawn heart for you guys to show you how we get our pulmonary capillary wedge pressure reading. So we have a heart, we have the pulmonary artery catheter. And this is threaded down through the right atrium and the right ventricle, and then floated up through the pulmonary artery. All right, so this is my pulmonary artery catheter here, sitting in my pulmonary artery. When we want to measure a wedge pressure, the provider comes in and inflates a balloon that is sitting in that catheter. And what that balloon does is it occludes our pulmonary artery, okay, from here back this way. This is our transducer, which is taking measurements. When this balloon is inflated, our transducer is only measuring what is in front of it, okay, because this is occluding everything back here. So our pulmonary capillary wedge pressure is a direct reflection of left atrial pressure, because this is my transducer. The balloon is inflated, occluding this stuff, and it's measuring here. All right, so wedge pressure gives us a reading of pressures within the left atrium, or within the left side of the heart. So what affects wedge pressure? Think about what valves you have on the left side of the heart. You have the mitral valve between the left atria and left ventricle, and you have the aortic valve in the left ventricle. So any mitral stenosis, any mitral regurgitation, any aortic stenosis, aortic regurgitation, any valvular diseases on that left side of the heart is going to increase that wedge pressure. Volume overload. So patients, again, in congestive heart failure or cardiogenic shock, where fluid is sitting inside of this heart that cannot propel it forward, and fluid is building up and up and up, that is significantly going to increase not only our wedge pressure, but it's going to increase CVP, okay? So basically, congestive heart failure is going to increase pressures on the right side of the heart and pressures on the left side of the heart, because of all the extra fluid that is not being offloaded, okay? It's not being propelled forward by the heart as it should be, okay? So that is the main hemodynamic measurements that I feel are, most important for you guys. This is just, or was meant to be just an overview of these values. Hopefully helps clear up maybe some misunderstandings, or any questions that you had about maybe what the values are or what they reflect. Make sure that you have that good solid understanding of blood flow through the heart, and this will make much more sense to you. And I just hope that this was a help to you, and that you can go out there and just kill it on your hemodynamics test. And I just want to thank you for learning with me today.